Lovely. Yeah, hi. So Pete Waddingham, Programme Manager here with the Yorkshire Humber Academic Health Science Network, and delighted to be putting on this event today. Thank you for everyone that registered and joined. As it says there, please feel free to just pop your name in the chat, your job title, the organisation that you're working for. I'm sure that'll help people that are on the call. And while you're doing that, I'll just whip through just a bit of a plan of action for today. So I'm delighted to welcome Professor Shafi Ahmed. I've stolen this job title straight from his LinkedIn profile: surgeon, futurist, innovator, entrepreneur, humanitarian, and I agree with all of those. I follow Shafi's work closely on LinkedIn and always enjoy listening to him, and really keen today myself to hear what he's been up to. And he's going to provide an overview of XR in training. Next, we've got Dr. Neil Ralph, Head of Technology Enhanced Learning at Health Education England. Again, really been a real privilege to be working with Health Education in England over the last couple of years, and they've been doing some excellent work on immersive technology, and I've certainly been following their work as well really closely, and some of their strategy that they've developed to lay out the framework and the context for this work. And Neil will be giving a background. Sorry if you could just pop yourself on mute, please. Neil will be giving a bit of a background and context to this project that we're working with, and I'm really hoping that we as an AHSN can add value to Health Education England's work. Helen Hoyland, Programme Lead for the Yorkshire Humber AHSN, will just give an overview of the role of an AHSN. I'm sure there's people on this call that have not really heard of AHSNs before. And more importantly, how we're going to support innovators. I'll then be taking people through workstream 1, which is around pipeline and demand signalling. We've got Adele Blythe from East North Cumbria AHSN, who will be talking around workstream 2, around regulation, case studies and real world evidence. And then finally, Lucy Brock, Head of Education and Simulation Programmes at UCL Partners, is going to touch on briefly on workstream 3, which is the impact of XR on training teams. And then we'll do a bit of a questions and answers if people have got those. If not, we will let you go. So some rough timings there, and I'm sure we'll have a good session today. So without further ado, let me hand over to Professor Shafi Ahmed.
Thanks, Pete. It's going to make sure everyone can hear me first, Pete. So thumbs up, Pete, if you can hear me. Good. So technology is working. All right. Now, next, let me share my screen. Give me 1 second. Can you see my screen now, everybody? I'm assuming that's yes. Okay, well, thanks, Pete, for the kind introduction and also for the invitation to speak. It's quite a good panel here that I'm seeing over the next hour and a half, and people have been at the forefront of XR and its perhaps use in medical training and also in healthcare as a whole. So I've got about 15 minutes to talk about my thoughts over the last decade or so on the work that I've done and work with my company Medical Realities in collaboration with other partners in understanding the space better. We are in a better position, of course, the last couple of years, and thanks to the COVID pandemic, we've seen the rise in use of new ways of teaching and learning, going from online platforms like Zoom and Microsoft Teams to now looking at XR platforms to enhance and, I guess, improve access to education. I think what XR will allow us to do is augment people's training. I thought I'd set the tone around the huge workforce issues that we're seeing currently in the NHS. This is not new, by the way. It's been going on for a long time, but now it's just been highlighted as being a huge problem as we go forward with people, of course, leaving the profession over the pandemic. Also, the fact that we've got huge shortages of a workforce across all sectors. If we look at a global view, and I do a lot of work on a global health strategy across different governments across the world and building their capacity and doing some modelling around that. This is going back a few years, of course, the WHO, and the data is probably slightly out of date now. But back in 2013-14, when they issued this report, they estimated that the global shortage of healthcare workers by 2030 would be about 15 million or so. I guess, looking at the way things are happening, that estimate is probably an underestimate. I'm sure there'll be many more millions that we would need to improve access to healthcare across the globe. That includes, of course, people from all specialties, including my own specialty of surgery. We saw during the pandemic the highlight of the backlog of surgical operations that need to be performed. In fact, look at the article from the BHS on the right-hand side by the group from Mary's and the Global Surge team. In the first 2 or 3 months, there was about almost 30 million operations that were cancelled because of the pandemic. Of course, we now know in the UK, we have over 6 million people now waiting for surgical operations and others waiting for diagnostics. So it's a huge burden, not just the UK, but on a global level. If you go back to 2015, of course, we realised that surgery was a problem globally. In fact, they estimate that 2/3 of the population of the world, that's 5 billion people, could access what's called safe and affordable surgery. So that's kind of context in the last 5 to 7 years. Data is quite difficult to get hold of in terms of capacity at the moment. It's very hard to work out what numbers we need going forward. Let's take an example here from Statista, looking at the US as an example, looking at how many surgeons will be short by 2032. But not all of that, but looking at all physicians. There's a huge discrepancy across the medical sector. If you look at all physicians, they're going to be about 80,000 people short by 2032. So we've got a huge problem. We've got a diminishing workforce. Our workforce needs to be trained in different ways. We've got to think about different models of learning, also how to retain people long term. We've seen our own problems with surgical training, of course, the fact that quantitatively people are doing less operations and training is not getting as much experience. Therefore, we need to think about that in a different way. Of course, I see that Neil is speaking after me, and Neil's been doing amazing work with HEE to understand this whole problem better. And hopefully, between all of us, all the stakeholders and parties together, we can come up with some solutions to improve this access, improve training, but also think about that workforce as a whole. And actually highlight it at the forefront of healthcare provision as we go forward. It really does need this consideration. We also help, of course, by global strategies. WHO produces its own documents around recommendations of health in the future as part of the, the UN Sustainable Development Goals, number 3, which is health and well-being, around digital interventions. They described about 3 or 4 years ago 10 interventions that would help. As we go on, of course, now they're building the WHO Academy of Learning in Lyon in France, but we're now looking at different ways of incorporating digital learning tools. In the UK, we're also very supported by major strategic documents, whether it's the Future of Surgery Commission that I was part of at the Royal College, or indeed the TOPA review, as you've heard of, around improving digital workforce, and also the Health Education England's own programme on technology enhanced learning. And Neil, I'm sure, will talk much more about their whole programme in XR in more recent times. If we go back to where we are in the world, a decade ago, the language of innovation technology just wasn't available. We're now seeing so many technologies coming together at the same point, of human existence. And therefore, we are rich in the technologies that we can apply. And XR is just one of many. You've heard of AI, of course, deep machine learning, and many others that are now impacting health. It's important to think about all of those together and how they work in conjunction with one another rather than stand alone. One of the key things about that is the connectivity pathway. And now, of course, we're seeing this whole world of 5G connectivity, which allows large download speeds of 1 to 2 gigabytes per second, but also a latency that's very low at 0.1 millisecond. Therefore, now we can do remote work in terms of remote surgery, robotics, but also allows that huge data to be captured using AR and VR and immersive tech. And one of my roles is I work for Vodafone as their Connected Health Ambassador, trying to understand the concept of connectivity, edge computing, cloud computing, and mobile networks, and how we connect hospitals and platforms so that they can work seamlessly together. Together with Deloitte, we've just launched the Centre for Health across Europe, and our main countries that we're going to be working in the first phase are the UK, Spain, Italy, and Germany. And we're launching that whole programme in a month's time. And hopefully we can think about what this looks like in terms of connected health going forward. In terms of XR, of course, you all know this very well, of course. The XR is a number of things, whether it's AR on one end, VR on the other extreme, in middle got mixed reality, and this whole concept of holograms, avatars, and the metaverse. All those combined form the definition of XR. If we go back a few years, this was me with the glass 2014, and you'll see also the kind of concept Apple bring out its own glasses, hopefully later this year. It's just a depiction of what it could look like in the future. As Apple and other companies come to the market, we'll see a much better utilization and a kind of content that's been provided across the world. 2014, I used the Google Glass. I guess you'd call it precursor of AR. And I trained 14,000 people across the world using a smart device by streaming live across the world using a 3G connection. It just showed you the power of connectivity and smart glasses at that time. This was 8 years ago, remember, a number of years ago. If you fast forward 2021 to the pandemic, I did the same thing with smart glasses, 5G connector called the GigaCube, which allows amplification of signal, and we stream live operations using the Rods and Cones platform, and supported by Johnson & Johnson and Vodafone. It's that collaboration, the industry partners come together to do live surgical operations. So that's the kind of thing we've been thinking of. And this is another example where I did a live operation remotely from, this was based in Arab Health, from Dubai to Belgium. So you can see that just use smart glasses, we're able to train people remotely. And now with these connectivity pathways, we'll be able to connect people on a wider scale, not just UK, but on a global level. VR is not new, of course. We know that VR has been around for a long time. It's just now we have the computing power to allow us to perform powerful tasks and use graphic designs and processors to showcase the latest tech. And of course, the headsets become smaller and in terms of the form factor, allowing untethered devices to perform well, using 6 degrees of freedom, motion tracking, eye tracking. That are becoming really much better and useful as devices. And medical realities, where I'm a CMO, Chief Medical Officer, we work with HEE actually and Neil's team around creating some of the content. And I think we're one of the few content providers on the HEE platform at the moment.
Shafi, sorry to interrupt. I'm guessing there should have been sound with this video now potentially, and there isn't.
Oh,
Only because you have to share your audio when you share your screen. However, to be fair, it wasn't ruining the experience for me because I was sat enjoying listening, watching it. But if that's
we can talk over it. So basically, let's just get back 1 second. Just get back 1 second.
Thank you.
Thank you for that. Thank you. So if I'm playing again now that I'll just turn the volume down on my side, but hopefully you have to hear the video. I'll tell you. So what we're doing now is creating content that's really interactive. So I think that's where VR adds value, where you can now do remote collaborations. You can connect with people remotely. I think that's going to be a huge advantage, and that kind of now lends itself well to remote kind of learning. We can also share 3D animations, and that's obviously being a very important one. But radiology being another one, we can actually come together and see 3D objects which you can interact together and share that same content. With a look at 360 videos, both creating CGI, of course, animation and simulation, but also looking at videos. So we're now working with Canon, for example, here, creating 3D content around digitalization of radiology and training, as well as now working with some anatomy partners and creating tools for both undergrad and postgrad training. We ended up recording many operations over the last few years. We've traveled to many countries recording surgical operation 360, and I did the world's first VR surgery in 2016, which was watched by an audience of 55,000 people across the world. But even 2D interfaces work well in the VR environment. And now the other option is around working in different groups from different parts of the world, but also, of course, around the UK. And the last bit is around conversation engines, training. This work with Fracture Reality has done with HEE, around looking at how you can converse with a patient, learn, put different scenarios in, and at some point there might be AI interfaces allowing you to navigate through a conversation. This is very important in history taking, consulting, professional skills, etc. And so I think these are the kind of advantages that we're seeing now. If you look at the surgical fraternity, we're seeing a huge explosion in simulation training. Also, VR have raised over $60 million recently, bringing in training for surgeons around the world. What they're creating is CGI simulation, high level. They haven't really added the haptics. Others have added haptics in terms of their processes. And so this is showing that actually it can improve the learning by over 260% in the paper they wrote a while ago with John Hopkins. So these are the kind of things we're seeing, and the validation's coming through. PwC produced a report about 2 years ago around the efficacy and outcome of this. And it's showing that people engage in VR learn much quicker, more confident, more focused, etc. So we're seeing the benefit. The Mazer report, I think about 7 years ago, showed that the retention rate were 80% higher than normal online or e-platform. So there is certainly evidence to suggest that it does add more value. And I just did a recent study with Imperial comparing learning in VR compared to online platform like Zoom and a face-to-face. The results of that will come out shortly with the work of Imperial College. Talking mixed reality, it's the other part, of course, of XR, where we're seeing HoloLens and things like Magic Leap, and both are now in second versions, which are very powerful devices, but they're quite expensive at the outset. The content's quite compelling. What we're seeing is surgical navigation. So you can actually now overlay information in real time for surgical training, but also for planning and operation, particularly useful for neurosurgery and indeed spinal surgery. So and a number of companies now have had FDA approval in using technologies for surgical practice. But of course, we're also seeing in real time, can you navigate through an operation in real time? And this is a company called HoloEyes from Japan, Maki Sugimoto and his team creating real-time images overlaid on a body. This is a liver operation being carried out. In the future, maybe what we'll see is proper navigation taking place. Here, of course, what we're seeing here is a smart ambulance from Milan. And what we're seeing here is the work with Vodafone in Milan, creating a smart ambulances. Now, I was actually speaking of the ambulance, Essex ambulance 2 days ago. They're very keen on trying new technologies to train their workforce. Here is a person wearing a mixed reality headset, the HoloLens here, relaying information real time to the hospital, looking at, they can see, watch the scans, they can view the, the physiology variables and make decisions in real time. And that obviously helps the golden hour of injury and illness. During the pandemic, when our students at Barts Medical School were unable to come to the ward, we brought the ward to them by using mixed reality headsets on the ward, doing ward rounds, bringing them into a local lecture theatre, social distance, so that they could get experience despite being away from the wards. So it's about thinking about different. The last minute or so about slides going forward, it's around the whole concept of avatars, holograms, metaverse. And I've kind of been working on this whole area for about 8 or 9 years, thinking about the future of remote collaboration is going to be very much digital humans, digital twins, avatars, holograms, and now, of course, this whole terminology around the metaverse. This is my avatar, actually, and I'll show you something we did in 2007. That's like 5 years ago, where I thought my avatar was really useful in this world of working remotely. This is me with the HoloLens 1 in the operating theatre at the Royal London Hospital, and I'm joined by 3 avatars, colleagues from India, from the Tata Memorial Hospital, one from the US, one from the UK, all joining live in my theatre at the same time, sharing images, scans, getting real-time support and advice and training. But actually, this, I thought, is the model of the future. So this was us back in 2007, remember, really early in understanding that we need to be more remote. And now the pandemic has hit us, of course, it's shown that we've got to think a different way of having remote collaboration as we go forward. So this is kind of where we are now in terms of metaverse. These avatars improved, of course. This is my hologram from a few years ago. What we're seeing now, this is my hologram created with 5G technology, a company called Double Me, who just raised a significant amount of money to create their metaverse. This was always scary at the time, but now holograms will become more and more routine as we go forward, and also creating digital humans. This last slide from me, this is me meeting my team in California. And actually what I show you now, of course, is that global handshake. As we connect together, as we go forward, we see that the world becomes a smaller place, more connected, and this is me shaking the hand of somebody who's remote in the same space together. So I thought I'd just leave you at that point to show you the kind of where we are, what the future might hold for us, and where this whole technology might actually improve our lives. So I'm just going to stop there, and I will stop sharing the screen, if that's okay.
No, perfect, lovely. Thank you for that. And as I said at the beginning, I'll say again, I always enjoy listening to your work and following your work, and some really good things in there for me to go and do some homework on. There's a couple of strategies at the beginning that I hadn't clocked actually, so I'm going to look at them. I had seen your work with Deloitte actually in Vodafone. I joined one of their webinars. I've seen their 5G Cube. Sometimes we talk about Wi-Fi being a problem to some of this technology, but like you said, it shouldn't really, because the technology is there, the lower latency, the bands that this VR can operate through. So technologically, it's growing really fast, and it's already there. So and some really nice examples. So thank you for setting that context. Really appreciate it. Let's keep moving through if we can. Next over to Dr. Neil Ralph. I've got your slides if it's okay, Neil. Would you like me to share? And then if you don't mind, just keep saying next slide, please, if that's okay with you. But thank you, Shafi.
Good afternoon, everyone. Thanks, Pete. Yeah, very happy with that.
2 seconds. There we go. It's just coming through now.
Okay.
And I had a feeling it'd probably start at the beginning again. There we go. So, oops, sorry, I've gone one too many. There we go.
Right. We're going to do a great double act now, aren't we, Pete? So marvellous. Well, it's wonderful to be here. It's fantastic that we're able to launch this initiative. So much appreciation to the team and for those who are joining us this afternoon. I've got the great pleasure of working for Health Education England and leading our Technology Enhanced Learning team, or our Technology Enhanced Learning function. For those of who are not too familiar with HEE or Health Education England, we're part of the NHS, and our role is around the education and training of the NHS workforce. And the Technology Enhanced Learning team's role is to act as an enabling function both within HEE or out there across the other national bodies, and working with our regional colleagues and our colleagues at the local level across the country. And our focus is on supporting the successful adoption, utilisation of learning technologies, digital approaches to learning, and also around simulation-based education. And HAG has been around for 9 or so years now, but for the last sort of 4 or 5 years, we've really scaled up what we're doing within that space. Shafi wonderfully illustrated a few moments ago nicely sort of touched upon the promise of what we can currently do with XR technologies right now, and equally in terms of how that's going to be evolving at a rapid pace into the future, enabling us to do more and more innovative and powerful things. But Shafi also picked up upon some of the challenges that exist in terms of our workforce in healthcare, challenges that are felt at the global level, and within HEE and within all sort of NHS bodies, we're consistently looking at how on earth we can innovate in the way that we train and educate to try and resolve those problems and put quality patient care at the heart of everything that we do. If you move on to the next slide for me, please, Pete. Smashing. So I mentioned that within the TEL team, as we affectionately call it, we've got a focus upon simulation-based approaches to education, as well as delivery of education at scale through our national learning platforms, for instance. The role we're playing within simulation is multifaceted, really. We've got a role to both evangelise and to provide some input with system colleagues in terms of the pushing forward in terms of the high quality adoption of simulation-based approaches to education. And as part of that work, we published this document that was also on Shafi's slides just under a couple of years ago, with a view of helping our system colleagues being able to understand how we can start to broaden the application of experiential approaches to learning and the techniques and arts of delivering effective simulation. But also how we can start to utilise and leverage different technologies to help us do that at even greater scale with even greater consistency. And immersive technologies or extended reality technologies and other use of video, for instance, are seen as a key component of our ability to start to really drive through the benefits of these sorts of learning approaches and increasingly understand their role in terms of delivering hybrid approaches to education, of which we're seeing driven absolutely by the necessity to do things differently due to the pandemic, but that really accelerated was what was already an emerging trend in terms of wider approaches to education across all sectors. If you move to the next slide for me. Thank you. So, as I mentioned, immersive technologies, immersive learning technologies, XR and otherwise, are seen as, well, we've got high expectations of them being incredibly powerful tools to help us innovate in the way that we train and educate. And what we're very keen to achieve within the TEL team and with our colleagues across HEE and wider is to make sure that health and care is in a position to effectively leverage those technologies and start to derive those benefits. And that's really important from my perspective to do that now, because this field is marching ahead at quite a pace. It's still a technology that some could say is in its infancy, but what we're seeing is an enormous amounts of investment being made particularly by the sort of mega tech companies out there. And huge amounts of innovation going on, and we're very keen that health and care can both benefit from those as soon as possible, but also we really truly understand the implications of adopting these technologies so that we understand as quickly as we can what we need to put in place to get that right. So we are playing our part within the TEL team to put in place different programs of activity and services that we hope will contribute into enabling that wide-scale adoption at pace, but that successful adoption. There's a little picture in the right-hand side there of the front of a publication called Growing Value of XR in Healthcare in the United Kingdom, and that was produced with a range of partners across the system. So it's very much a connected world that we're sitting in. There's an awful lot of partners and stakeholders that are working with us to try and achieve some real impact from this work. If you move on to the next slide for me, Pete. Thank you. So just to give you a flavour of some of the things that we're doing at the moment, which we're hoping this new initiative will support and contribute into. We've got a few things I wanted to highlight to you. So one of the things we've been doing, which was largely driven by initially to try and support some of our colleagues across postgraduate medical education, but more widely due to the impact and disruption due to the pandemic, we created we made some investment into some XR technologies, and we created what we call our XR hubs, which is a virtual library of hardware and applications which we're able to loan out to the system. Now, one of the driving forces or the ethos behind the approach we take within the TEL team is as far as possible to enable a level of equity or democratization to learning technologies or access to equipment that facilitates education. And so by creating a virtual library, we're enabled to find access to parts of health and care who may not easily be able to buy into XR technologies, and that's either to be able to utilize that to deliver an educational intervention, or to test that out within their environment, or to help them build a business case, to help them start to generate the evidence where they may be able to attract some investment locally or within their own organizations. So that's part and parcel of what we're trying to do with the XR hubs in terms of supporting that adoption, but equally sitting within that is the ability for us to really get a handle on what it means to bring these technologies into that working or educational environment. And linked to that, we've got a role to work with system partners to create guidance and to be part of contributing to that evidence base, and to create some supportive documentation or otherwise, that further facilitates and scaffolds people's ability to bring this technology into play. And then last thing to mention on this slide is that we will always be quite limited by what we can achieve within a national programme or within the constraints of the programmes and services that we've got. We want to be able to provide support at scale across the country or even wider. And so what we're keen to do over the course of the next year is work with system partners around how we can create innovative approaches to procurement and adoption of these technologies. How do we support purchasing organisations and individuals and commissioners to approach the idea of buying into XL technologies with confidence and with a sense that they're going to be making really good purchasing decisions around that. So there'll be a lot more to come from us with that work soon. Next slide, please, Pete. So the last slide from me, and hopefully I'm just giving you a little bit of a flavour of what we're doing within the TEL team. You can always follow up with me for more information. We're incredibly keen to be working in partnership with the academic health science networks. They've been a strong partner in many ways across many different sort of initiatives within HEE at a national and at local scale. And by working with them in this space around XR adoption, we get the opportunity to tap into the expertise that sits within the networks. And their ability to both have very close relationships with local NHS partners, with academia locally, and with commercial industry as well. And at the same time, one of the things what we want to achieve as we're moving into increasingly supporting that adoption of XR technologies is the ability to see new innovation, is to see a real opportunity for new products, new innovations to be able to be exposed to health and care, which enables us hopefully to move at some pace to solve some of the problems that we need to solve, or to drive forward the highest possible quality products that then are made available to our educators and our learners, and hence our workforce out there across the system. So that's everything from me, Pete. Very much looking forward myself to the rest of the session this afternoon, and this is the start, I think, of some very exciting work that we're going to be doing together.
Lovely, thank you. Oh, got an echo there. Thanks for the context, and as you said, the work that hopefully we can complement, which we're going to give people a flavour of now. So I'll hand over to Helen, and she will talk you through just a bit about the role of the AHSN and how we do currently support innovators, and how that dovetails to the work that you're talking about, Neil. So over to you, Helen.
Thanks, Pete. So hi, I'm Helen from Yorkshire Humber AHSN. Can I just say that I am in a open plan office in Leeds at the moment, so please do bear with me, and apologies if you pick up slight background noise. So we're really pleased to be launching this project today with Health Education England and our other AHSN colleagues from across the country as well. Next slide, please. Thanks. So we're one of 15 AHSNs. We're funded primarily from NHS England and the Office of Life Sciences, and we're set up as the innovation arm, essentially, the innovation delivery arm of the NHS. There's 15 of us. We work closely together, and we're right across the country. So please do reach out to your local AHSN. Next slide, please. Thanks. So essentially, we act as a bridge. We describe ourselves really as an honest broker between healthcare providers, systems, commissioners, academia, and industry, and we connect all of these sectors. So we act as that honest broker and that sort of boundary spanner across the whole of the innovation ecosystem across the country. Next slide, please. So our main sort of mission statement essentially is around improving health, populations and patients, and patient experience and outcomes, reducing costs and improving quality, and working around improvement, and also economic as well, so growths and jobs and investment leveraged into our respective regions. Next slide, please. So what's our role? So we support the NHS stakeholders, as I've said, around adoptive technology improvement. We work directly with innovators, so that's large industry and SMEs as well, to help develop their innovations, bring them to market, give them advice and guidance and signposting, and then we support the adoption of those innovations into the system, so that we're here really to help with the accelerated adoption of innovation. And we work closely with the Accelerated Access Collaborative in NHS England to achieve some of these goals. Next slide, please. So we have an innovation pathway which takes us right through from early stage ideation right the way through to successful adoption regionally and then hopefully nationally as well. So we have a comprehensive offer that we give to innovators and industry across the whole pathway, which you can see represented here. Next slide, please. And so each AHSN has what's called their innovation pipeline. So we have a cohort of SMEs or innovators that we support intensively throughout their journey. And they could be at either of those three main stages of the pipeline, depending upon their maturity. So as I say, we have that comprehensive offer, and we're really, really pleased and interested to be able to work on this project here, looking at particularly around these immersive technologies and to think about in the future, how can the AHSN support this type of technology, help bring it to market and help meet some of the unmet needs of the future, particularly around the workforce.
Can I just interrupt? Sorry, Helen. The slides are changing for me and I presume everyone else, but there's a comment in the chat that the presentation is not. Is everyone seeing the latest slide, which is a kind of blockbuster type of look?
I can see Helen's slides, Pete.
Yeah, lovely.
Yeah, I think
I can.
Okay.
So, yeah.
Oh, thank you. I thought that might be the case.
No problem.
Sorry, Helen.
That's all right. I've just got a couple more. So if we can move on to the next one. So I think, you know, generally speaking, we're working with whatever type of technology, digital med tech, devices, you know, these are some of the questions that we encourage our innovators to think about and also have these types of conversations with our health systems and partners as well. And these are some of the complex sort of questions that the AHSNs can help you navigate. But these are really, really important where we want to bring credible innovations to the adoption phase. Next slide, please. I'm not going to touch on real world evidence greatly because I think Adele's going to pick that up in a section later on. But just to say that we do commission real world evidence studies across the AHSN network using this sort of PICO methodology. And we're really, really interested to understand about how will this sort of impact on XR and VR in the future, and how do we talk about the sort of the benefits realisation and the level of evidence required from commissioners and procurement people in the NHS in the future to bring some of these innovations to business as usual. Next slide, please. Oh, that's it. So that's me, a whistle stop tour of the AHSNs. Please do reach out and yeah, just really excited to be part of this project going forward. Thanks, Pete.
Lovely. No, thank you. It's my turn now. And I did say to Helen, Pico is actually the name of a VR headset. Other headsets are available. Yeah, hopefully we'll touch on some of the work now of workstream 1, which is around pipeline and demand signalling. So just a couple of areas that I'm going to ask for your help on. As Helen described, we do have a pipeline at the moment. There's 15 AHSNs up and down the country. We've got a registration page. In a minute, I'll post that in the chat for people to register. Don't worry, we share information between us. I'm also going to give a very quick reference to a new front door, if you like, called the National NHS Innovation Service. And again, that will make sense of why I'm bringing that to life in a minute. But really what I'd love to get some help with today is around a taxonomy for HR and also start to get a flavour of what some of the support you as XR companies may need from an AHSN. And I'll put the link in the chat now, what I'm going to talk about in a couple of seconds. I'll briefly touch on some work around market and clinical needs signalling, and then I want to just highlight some innovation surgeries that we've got planned on the 7th of 24th of June, and we want to start getting some expressions of interest from XR companies who may like to be part of that, and that'll help us cover some of the areas that Helen's touched on. So yeah, I mean, as I said originally, the Yorkshire Humber AHSN, we have a landing page, we have a form that people can fill out, name of organisation, area of you know, innovation, etc. Some other key areas of questioning, and that allows us to do a bit of that sifting through, and we do that for everyone. As it says there, that's a Yorkshire Humber AHSN page, and the link I'll be sharing is a Yorkshire Humber AHSN page. But this project is working with East North Cumbria and UCL partners, and we'll be sharing that information between us and with the wider network. Just as I said, a little sort of reference to the NHS Innovation Service. That hasn't launched yet, but it will be launching soon. And again, it's just really another front door to help innovators. But behind that are lots of organisations, and as you can see right at the top there in bold, where one of those, but equally Department of Trade are involved in there, NICE, National Institute for Health Research. So it was just really, if you happen to see the launch of the NHS Innovation Service, don't worry, you might register with that, you might provide the details, but certainly it will make its way back to us, which is ideal really, because we want these front doors, these pipelines to really work, and for us all to be connected, so we know what innovation is out there. And as I said, that's the sole reason of that service as well. Yeah, in terms of the pipeline, the taxonomy work, which I'd like to get a bit of help with, and not today. It's you know, you can look at it at your own leisure. You might have a look at it now, the link that I posted in the chat. But really, that taxonomy tries to cover things around stages of development. So where are companies on that pipeline? And it's absolutely fine, as Helen said, to be early idea right through to oven ready and rolling out. And we just need to be able to understand where companies are on that development pathway, so that we can help. So the form aims to capture that, and that's what we'll be looking to do in the future. Obviously, clinical area is really important. What training needs it covers, the type of equipment being used. We know there's lots of equipment there. Geographical coverage, I've tried to take a bit of a pragmatic approach and base it on an AHSN footprint, rather than get too micro. But it's really useful for us to know if someone said, actually, we're delivering this project within the Yorkshire Humber AHSN footprint, that actually might be enough for us just to kind of make that connection. And then when we get into some closer conversations around, well, I'm currently delivering in Leeds or Hull, sometimes that intelligence really helps us with spreading adoption, knowing where it's delivered. But as I said, I didn't want to go down too micro, so I've tried to base it on an AHSN footprint. There's a question in there around support needs. So what do you need from us? Is it that you need evidence generation, access to funding, brokering, etc.? So standard questions that we ask. And I wouldn't be able to sleep at night if I didn't throw in something around environmental sustainability, because it's an area that I'm leading on. So it's one of these areas that's getting more and more traction. NHS will require it through procurements that companies have thought about their environmental sustainability. And we're doing a lot of thinking in this space. So you don't have to worry if you've not done anything. It's a really kind of simple yes/no question, but it's just useful for me to start getting a bit of a yardstick of, as XR companies, have you thought about the whole life cycle of your product as a business, you know, your green credentials? Because as I said, it's a mandatory requirement of all procurements going forward. And then that survey I put together, I've just had a test of it this morning. It took me less than 3 minutes to fill in because I know everyone's really busy. But what I'm after is, does it cover most areas, most scenarios with your product service? You know, would it give an accurate reflection? Any areas need updating and tweaking? So there's a little section there for you to feedback. So as I said, you don't have to do it now, but I would welcome your input. I won't touch on this again. It was just to be clear on the stages of the pipeline. We have kind of classifications, and in there you might not be able to say it that clearly, but for example, where we might class you as deploy, spread, and adoption, that might be where we're getting into the brokering needs and requirements. So sometimes it's just a useful diagram to review where you are on the journey and what help you might need. Final couple of slides. So just in terms of market signalling and taxonomy, I just wanted to bring a live example. And I was asked to speak at the UK Emergency Surgery event yesterday in Leeds, hosted by the NIHR. It was really good. I was actually asked to speak about environmental sustainability, funny enough. And there was a great discussion about increasing the use of laparoscopic surgery due to its effectiveness and patient outcomes, etc., etc. And obviously training and education will be key to this. And I think that's an example of you know, how we want to be able to tell innovators, to tell XR what might be the pull from the system B, where might be the areas of focus. And obviously when we look at, like Shafi's shown, you've got brilliant headsets with great haptic feedbacks. You know, these are the kind of clinical areas that might be suitable. But at the moment, in terms of a taxonomy, we've not really got a way of being able to put our finger on the pulse quickly. So, you know, it's in our interest to be able to go, right, we've got this product that can do surgical intervention, you know, in this setting. So that's what we're trying to get to. Just to put a caveat with that, that was just my example. I'm not clinical, and I'm sure, I don't know if any XR companies are working in that space at the moment, but I do know there's lots of simulation equipment being used in this particular example. Another one that I just wanted to bring to life as well, because I'm collaborating with one of our ICSs around primary care workforce. And some early conversations are about how to encourage nurses into primary care and using immersive tech as a way to do that training and education. So again, for me, that's really good, demand signalling that we need to be able to give to innovators to show the types of use cases that people are looking for. And primary care, as we know, massive workforce, big contributor to the NHS. And hopefully in this project, we can get under the skin of some of that a little bit more, just help with our classification of what we've already got, highlight some gaps, etc., etc. If anyone wants to put any clinical pulls, needs that they're aware of in the chat, please feel free. We'll collate some of them because, as I said, it's really useful intelligence. Just finally then, innovation surgery. As I said, we've got some provisional dates of the 7th and 24th of June. We're looking for expressions of interest. Just we'll put in the chat, how to contact, reach out to me, just let us know if you're interested. It just allows us an innovation surgery to spend a bit more time with you as companies, understand what your offer is, understand how we can support you. And those will always be done in collaboration with key stakeholders. We might bring people in depending on the subject area, depending on the specifics. We'll obviously be working with other AHSNs, subject matter experts and industry experts. But yeah, a good opportunity for both parties to get to know each other a bit more. I think it'll be ideal for those organisations, those XR organisations that are not yet known to the NHS, who might need some of our support around evidence, clinical partners, etc., etc. So, as I said, please start expressing interest if you're interested in being part of those, and we'll get dates in diaries. I think that's it from me, so I'll hand over to Adele, please.
Afternoon, everyone. Thank you very much for the introduction. So the East North Cumbria AHSN are focusing on workstream 2, which is around regulation, case studies and real world evidence. And obviously Helen just briefly touched on real world evidence before as being part of the AHSN pipeline and pathway. So essentially, what we're looking at really as part of this exercise with HE is not really to deliver in this short space of time what the real world evaluation template is going to look like, but essentially it's looking at what it is and why do we need it. So I'm not going to read it verbatim, but essentially evaluators seek to provide that critical assessment through various robust and real world processes to allow us to understand whether any aspect of healthcare and whether or not the technology is going to meet its objectives, but it helps to show that real world impact to help accelerate spread and adoption. So some technologies can be developed in controlled environments, but we don't actually adequately capture the challenges of in-practice usage. And obviously without evaluation, all we have is advocates and champions, which can actually prohibit procurement, which is obviously what Neil was mentioning before as part of the HE programme of work as well. But essentially, what does this mean for immersive technology? So we need to work towards a place where we can test the products. You can have the sort of utilising existing sim technical expertise within the regions to help deliver these real world evaluations, which looks at things like economic health economic impacts, safeties and patient benefit, etc. So part of this work stream is we are looking to work with the key partners to identify these gaps in the base which may prohibit investment and the utilisation of the XR in the pathways. As I said, it's not to come up with the answers, but it's to see what actually do we need to support SMEs with in regards to real world evaluation to allow their products to get adopted by the NHS and obviously the healthcare system. Next slide, please. So the other element that we're looking at is around regulation, and currently the XR solutions have to meet standards and assurances which aren't fit for purpose for the unique applications of XR. So current regulations are aimed at things like digital technology platforms like DTAC or AI technology, which is governed by the MAS and the NICE guidelines. However, it's limited information regarding regulations, and initial conversations with NICE as it sits out without that remit. So what does that mean for XR SMEs? Because there needs to be clearer procedures and processes in this approval and governance, again, which is critical to supporting a thriving XR and healthcare education and training. So again, part of this programme of work is really working with key partners like NICE, MHRA to identify where these gaps are and to see whether and how we can make XR products, so they can demonstrate that they're safe, operable, secure and effective, again, so they can be more easily procured. So part of this work as well is looking at some case studies and pulling these together to kind of really demonstrate where either technology has been effectively procured and adopted, and maybe some of the barriers that we have had along the way around the real world evaluation, maybe ethics, etc. So at the end of this, we will have 4 really hopefully good case studies to kind of present back on where these barriers have been and how companies have overcome them. Thank you very much.
Lovely, thank you. And last but not least, Lucy, if you'd like to take people through the impacts of XR on training teams for Workstream 3.
Pete, thanks very much. Yes, so let's have the slide. Thanks, Pete. So what I can demonstrate on this slide is the output of some of the best educators in London. So I've worked for the London Simulation Network. Essentially, we host that network of simulation educators, and I'll walk you through what's happening in these 4 images, and I want you to think about the knowledge of the training team, how they achieve this, and I'll explain why that's what we're going to do. So in the top left hand corner, you'll see there 2 experienced critical care nurses, a perfusionist and an ECMologist and someone else, and they have simulated a cardiac arrest in a patient with ECMO, and we can consider the kind of technical competence of both the clinical staff, the technicians, the simulation team, and the debriefers to design and deliver that. And then on the right hand side, top right there, you've got a debrief. It's a discussion, it's a facilitated discussion. And again, I want you to imagine the skills of the facilitators to break down perhaps a scenario like the one that you're seeing on the left. On the bottom row, we've got some part task trainers and the kind of skills of establishing a workstation which is usable by the participants, can be repeated, and gives a lifelike or somewhat lifelike semblance of, I think they're putting eye gels in down there as a aid to kind of intubation. That's my hand in the middle, and a technician taught me how to simulate a cannula. If I ever needed to do that, I couldn't tell you why. Maybe we had some downtime. and at the bottom right, we're training there in surgical skills. So that's fine motor skills, learning, you know, I think this is basic surgical skills of learning how to suture and tie knots, use simple pieces of equipment. These are delivering this is the skills and mainstay of the faculty and technicians who deliver some of the most interactive and important education away from the clinical bed space. And Pete, if you just click over, I think the disruption that virtual reality, extended reality, augmented reality causes for these teams is exciting. There's loads of potential, but it's a real challenge, and they're being asked whether they can use new technology to deliver existing training. I thought it was really interesting that Pete, we can actually just kill the slideshow now, that's fine. It was really interesting to me that just maybe the whole screen share, thanks. That Shafi Ahmed was saying that the role of XR is to augment education. But I think sometimes there's this perception that it's rather than augmenting, perhaps it's about replacing, because you hear things said like you'll reduce time in face-to-face training, or it will reduce, I mean, people can train remotely, and these things are true, but then we get into a kind of confused state as educators and facilitators of what really is XR for, and how can we make best use of all the opportunities to increase access to education and training and make healthcare safer and increase the workforce pipeline and so on and so forth. So this is the challenge that education teams in hospitals are faced with at the moment. And I think there are a lot of questions that we need to answer about we need to help them answer their capability and their knowledge to implement virtual reality, augmented reality, haptics, whatever it is, into training programs, into medical curricula, into multidisciplinary training, recruitment, wherever we are. And there are some questions that, or some areas of study which we've come up with, and we're going to go and speak with teams within London to find out what their training needs are. So this is the training needs of those who will be implementing extended reality. And maybe it's about how much experience they have themselves with extended reality and their understanding of the different types and when they should or shouldn't be used. Or maybe it's about their organisation's digital capability. Do they have any sense of what that is? And there's lots of work going on in the TEL team about that. Or is it that they haven't worked with industry before? Perhaps this is an area of focus for them. So we will go and do focus groups and structure conversations with members of the London Simulation Network. This covers 31 hospitals in London, or sites in London. The newsletter, it's got a membership of 300 practitioners, and the newsletter's opened something between 500 and 1,000 times each month. So that's the sort of range, and we've got strong relationships as an AHSN with all of those training centres, and we'll go and do that work alongside a partner HEI. So what I say is, if you're interested in that work, if you want to shape it, if you want to hear about the results of it, if you want to help us ask the right questions, or even indeed help us ask the questions themselves, then I'd ask that you get in touch, and I'll put my email address in the chat.
Lovely, thank you for that. We're nearly finished. I'm just going to share my screen one more time. Not a lot on it really, but it was just an opportunity. If people wanted to ask any questions, then we could take some. I'm not going to force it. It is Friday afternoon, but I will have a look. Actually, let me just stop sharing my screen. I'll make it slightly smaller just in case I see any hands going up. So yeah, just an opportunity. Does anyone want to ask a question